If you blank on ankle OSCEs, it's usually not because you don't know enough, it's because you're not using a structure. In the next few minutes, I'll show you a simple way to go from a broad differential to a focused diagnosis without guessing or running unnecessary tests. It starts with one thing, the mechanism of injury. If a patient rolls their ankle inward and has lateral pain, that usually points you toward a lateral ankle sprain. You can often recognize the diagnosis before you even examine the patient. The reason students miss this is they try to memorize too many tests instead of recognizing patterns early. High performers don't start with special tests, they start with mechanism. From here, we'll follow a simple sequence, start with safety, then identify the pattern, then use a key diagnostic fork to guide your exam. This is how you move efficiently from a broad differential to a focused diagnosis. I'll show you the one key diagnostic fork that tells you exactly what to test and how to recognize the injury before you even touch the ankle. At ScrubNotes, we approach every chief complaint using the same three-step framework. Safety first, then patterns, then key diagnostic forks. This structure helps us move efficiently from a broad differential to a focused diagnosis. For this case, we have a 21-year-old female college basketball player with ankle pain. When evaluating ankle pain, we start by clarifying the complaint. Where exactly is the pain? Was there an inversion or an eversion injury? Were you able to continue playing? And at the same time, we screen for red flags like inability to bear weight, severe swelling or deformity, bony tenderness, or neurovascular symptoms. These findings raise concern for fracture, severe ligament injury, or an Achilles rupture. So before anything else, we want to make sure the ankle is structurally safe. This is our starting differential for ankle pain. Instead of memorizing dozens of diagnoses, we group them into categories. So mechanical causes like lateral ankle sprain, syndesmotic injury, deltoid ligament sprain, peroneal tendinopathy, and then we have serious causes like fracture or an Achilles tendon rupture. And don't forget overuse causes like stress fracture or tendinopathy. The goal is not memorization, it's identifying which bucket the patient falls into. The history provides some of the most important diagnostic clues. One of the most important questions you want to ask is, what were you doing when the pain started? Be sure to ask about pain characteristics, like if there's lateral ankle pain, you might be thinking ATFL sprain. If the pain is medial, suspect the deltoid ligament, and if it's more posterior, that's more likely Achilles. For ankle injuries, mechanism is everything. If it's an inversion injury, you'd be thinking about a lateral ankle sprain. If there's external rotation, maybe more likely syndesmotic injury. Posterior pain with a push-off, I'd be thinking about Achilles. We also screen for red flags, so asking if the patient can bear weight, is there severe swelling, and was there a pop? And if trauma is present, we apply the Ottawa ankle rules. This helps determine if imaging is needed. Let's apply this framework to a case. We have a 21-year-old female college basketball player who presents with right ankle pain one day after landing awkwardly from a rebound. She describes rolling her ankle inward, so inversion, and felt immediate lateral ankle pain, but was able to limp off the court. Since the injury, she rates her pain at a 6 out of 10, and it's worse with walking or cutting movements. There's mild swelling over the lateral ankle, no numbness or tingling, and there's difficulty with push-off, but she can bear weight. She's had no prior ankle surgery and no systemic symptoms. This slide outlines the ScrubNotes musculoskeletal approach for ankle pain. First, the pre-3 safety screen. In the pre-3, that's where we check for trauma, we do a fracture screen, we want to make sure that they're able to bear weight, we can use the Ottawa rules to help us with that, and we want to check for any instability or severe pain that might be indicative of a ligament tear. Second, pattern recognition from history and motion. Third, a diagnostic fork to help narrow the differential list. And only then do we perform targeted ortho testing. This stepwise approach prevents random testing and makes the diagnosis much more efficient. If you're in that quick review phase before an OSCE, I've organized these into concise decks. Links are below. The pre-3 is your structural safety screen. It answers 3 questions. First, use observation to look for swelling, bruising, or deformity. Second, check for fracture screening. If trauma is present, apply the Ottawa ankle rules and palpate key bony landmarks. Third, active range of motion. You want to examine dorsiflexion, plantar flexion, inversion, and eversion. The key idea is this: before running special tests, confirm the ankle is safe to examine further. Once we've narrowed the differential list, we can run targeted orthopedic clusters. For lateral ankle sprain, think about anterior drawer or talar tilt. For syndesmotic injury, you could do a squeeze test and external rotation. For Achilles, Thompson test is classic. Again, the key idea is selection. We choose tests based on earlier findings and questions. If you want quick visual summaries of these clusters, they're included in the ScrubNotes Orthodex. Now, here's the key diagnostic fork. This is where things start to simplify. After the pre-3, we look for pattern clues. Inversion injury with lateral pain, it's indicative of lateral ligament sprain. External rotation mechanism at play, syndesmotic injury is likely. Push-off weakness, think Achilles. This fork determines which orthopedic tests we actually run. Instead of testing everything, we test with intention. Let's apply this to our case. The pre-3 shows no fracture, and the patient can bear weight. There is mild lateral swelling. Active range of motion shows pain with inversion. On exam, we found there was tenderness over the ATFL. Inversion stress reproduces her pain. The anterior drawer test was positive. Squeeze test and Thomas tests are negative. When we follow this framework, the pattern clearly points to a lateral ankle sprain. At this point, we refine our differential list. Lateral ankle sprain is now my leading working diagnosis, but syndesmotic injury is less likely due to negative squeeze test. A fracture also seems unlikely at this point given weight-bearing ability and lack of any bony tenderness. And last, Achilles rupture also seems unlikely given there's intact strength. Putting everything together, we can present our case assessment. So we have a 21-year-old female college basketball player who presents with acute lateral ankle pain following an inversion injury sustained during play. History demonstrates a classic mechanism with immediate pain and mild swelling, while still maintaining the ability to bear weight, lowering our concern for fracture or complete ligament disruption. Physical exams today revealed focal tenderness over the lateral ankle ligaments, with pain reproduced on inversion stress testing and a positive anterior drawer, while syndesmotic and Achilles testing are negative. Presentation is most consistent with a lateral ankle sprain involving the ATFL ligament, likely a grade 1 or 2 based on preserved function and absence of instability. There's no evidence of fracture, syndesmotic injury, or an Achilles tendon rupture here. Before we finish, here are 3 common mistakes students make and how you can avoid them. First, skipping the auto ankle rules. This can cause you to miss a fracture. Second, ignoring the mechanism of injury. Inversion injuries point towards a lateral sprain. External rotation suggests syndesmotic injury. And then third mistake is over-ordering imaging. Most ankle sprains are clinical diagnoses, so use pattern recognition to guide your testing. To summarize the ScrubNotes framework, first, run the pre-3, so use auto rules for fracture screening, order imaging if you see severe pain or instability. You'd suspect a ligament injury if there's any instability. Second, identify pattern clues like an inversion injury, suspect ATFL. If there's push-off weakness, think of Achilles. And third, use a diagnostic fork to guide your testing. So anterior drawer test is positive, think ATFL. If there's talar tilt, think CFL. And if the squeeze test is positive, suspect syndesmotic. Remember, when ankle pain follows an inversion injury with lateral tenderness, the most likely diagnosis is a lateral ankle sprain. Once you start thinking in patterns and forks, ankle pain becomes much easier to approach. If you want a quick reference versions of this framework and all the orthopedic clusters and tests, they're included in the ScrubNotes Orthodex linked below. And if you found this helpful, check out the rest of the ScrubNotes Chief Complaint Series, where I break down other presentations using the same framework.